Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. After the presentation, we will conduct a question-and-answer session. To ask a question, please press star followed by the number 1. This call is also being recorded. If you have any objections, you may disconnect at this time. Now I'll turn the meeting over to your host, Deanna Ramirez. You may begin.
Thank you, Daniel. Good afternoon, everyone, and welcome to the Southwest Affiliate Stroke Bootcamp series. We are excited to offer this 15-week course as a way to educate stroke coordinators and key components of their role, provide tools and resources to build and maintain successful programs, and to assist in building a large network of peers. Before we get started, I would like to go over just a few housekeeping items. To avoid background noise, as Daniel stated, all lines have been muted. For questions, you can unmute your line by pressing star 1, or type in the Q&A section of the WebEx. Please note you will only be able to claim your CME CE credits at the end of the 15-week series on September 27th. A copy of today's slides and any handouts will be sent to you within a week of today's call. For future webinar offerings, including the Stroke Bootcamp webinars, please visit www.heart.org/SWA quality. Now we will begin today's webinar. I would like to introduce Stacy Moy. She has been with the Houston Methodist System for approximately 10 years, 5 years as an ED nurse and 5 years as an inpatient stroke nurse practitioner. She is currently working at the Houston Methodist Hospital, the Woodlands campus, with inpatient neurology and stroke team. Stacy?
Hi, thank you for the introduction. My name is Stacy Moy. I'm excited to do this neuroanatomy lecture. Neuroanatomy is very intricate, so it can be somewhat daunting and complicated at times. My favorite mentor once told me, you learn stroke one stroke at a time. It took me a little bit to understand what he meant by that, but I really think he means that you're putting all the puzzle pieces together. Your history, exam, imaging, anatomy, and that's, oh, I'm so nervous, guys, please. So back to this, stroke, you learn stroke one stroke at a time. So I don't have any financial disclosures. I do want to point out some pictures were used from Apex Innovations Hemispheres 2.0, the stroke competency program. The objectives today will be epidemiology, brain anatomy, vascular anatomy, anatomy seen on CAT scan, and then applications of anatomy to stroke symptoms. Can everybody see this poll 1 question? Can you tell by looking at an MRI of a brain if the patient is female or male? This is the question that my 5-year-old asks every night when I'm looking at patients from home. He always asks, are you looking at a girl's brain or a boy's brain? And the answer is truly, no, you can't tell if you're looking at a female brain or a male's brain. However, I tell him the girls' brains are always bigger. Moving on. There are 206 bones in the human body, 8 cranial bones. You have a frontal bone, which forms your forehead, an occipital bone, which forms the base of the skull. You have 2 parietal bones, which make up the roof of the skull, 2 temporal bones, right and left side. They're situated at the base and the side of the skull. Your ethmoid bone, which is not pictured here, makes the inner orbital socket. And then you have 1 symphoid bone located in the front of the skull to form the outer orbital socket. These bones are all joined together by sutures, and they form the neurocranium, or the cranial cavity that surrounds and protects the brain. Bear with me. There's a lot of information on this slide. The several bones of the visceral cranium are joined by sutures to each other in the neurocranium, except for the mandible, which articulates from the temporal bone. There are 14 facial bones, which you see on the diagram. I do want to point out that this slide also demonstrates the orbit or the eye socket, which is the cavity located in the skull in which the eye and its associated appendages are housed. The orbits are conical, sometimes described as a four-sided pyramid-like cavity that open in the midline of the face and point backwards. To the rear of the orbit, you have your optic foramen, which opens into the optical canal through which the optic nerve and ophthalmic arteries pass. The primary functions of the orbit include protection of its delicate contents through muscle attachment and smooth coating fascia, which also promotes and helps with eye movement. I read somewhere, but I didn't have a reference for it, that your zygomatic bones are the ones most fractured in facial trauma. This is the base of the skull. You have your anterior cranial fossa, which holds the frontal lobe. You have your middle fossa, which holds the temporal, parietal, and occipital bones. And then you have your posterior fossa, which holds the brainstem and cerebellum. In anatomy, a foramen is any opening. So the foramina we have many foraminas inside our body, which usually allow nerves, arteries, veins, and other structures to connect from one part of the body to another. The human skull has numerous foramina through which cranial nerves, arteries, veins, and other structures pass. The skull bones that contain foramina include the frontal, ethmoid, symphoid, maxilla, palatine, temporal, and occipital lobes. On this picture, you can see the foramen magnum. It's located in the occipital bone. It allows the passage of the spinal and vertebral arteries and the spinal cord to pass from the skull into the vertebral column. This slide demonstrates the protective layers of the brain. Physical protection of the brain is provided by the skin, periosteum, and the skull. The skin is the outermost surface. The periosteum is a dense, fibrous layering containing blood vessels that covers and protects the bony surface. The skull is the hard bone that encases the brain. You then have your epidural space, which is technically a potential space between the skull and the dura mater. It only exists when there's blood in this space. Epidural bleeds are usually from trauma. Cranial meninges consist of 3 protective membranes. You have your dura mater, your arachnoid mater, and your pia mater. Dura mater, the periosteal, tough, fibrous outer layer of the dura mater, and then it adheres to the periosteum of the cranial vault. Right underneath that, the inner layer, or the other side of the dura mater, is the meningeal layer. And it's usually fused with the periosteal layer. It is involved in the formation of the dural folds and continues into the spinal cord. Subdural space is the space between the dura mater and the arachnoid space. On this side, you have the arachnoid mater. It's the middle or the inner protective layer, which is soft and spongy. The subarachnoid space and the cerebral spinal fluid spaces between the arachnoid mater and the pia mater. CSF is a clear and colorless fluid. It circulates the spinal cord and the brain, and we'll go over that in more detail momentarily. Pia mater is the innermost layer which directly surrounds the brain. It contains the blood vessels that travel into the brain. Brain tissue is gray matter. This is indicated by the cortical ribbon, composed of nerve cell bodies and their dendrites, comprised also of the central processing unit of the brain and spinal cord. White matter is composed largely of myelinated nerve fibers, constitutes the conducting portion of the brain and the spinal cord. Here's another look at the space contained in the brain. As you notice, these are the places in which our patients have hemorrhagic strokes. We discuss these bleeds later on in the presentation, but the subdural spaces between the skull and the dura, epidural spaces between the dura and the arachnoid, and then your subarachnoid is between the arachnoid and pia mater. I get really excited when I see real pictures of the brain, but I do think this picture demonstrates the delicacy of the brain dura matter in the arachnoid space. This picture of the brain, this picture demonstrates the brain regions, including the 4 lobes and a few internal structures. It's important to note that the human brain is the center of the human nervous system. It's estimated to have 80 to 120 million neurons or nerve cells. Despite being protected by the thick bones of the skull, suspended in cerebral spinal fluid, the brain is isolated from the bloodstream by the blood-brain barrier. The cerebral hemispheres form the largest part of the brain and are situated above most other brain structures. They are covered with a cortical layer. They have a convoluted topography. The cerebral cortex is essentially a sheet of neural tissue, and it's folded in a way that allows a large surface area to fit in such a small area confined to the skull. The cortical folds are called the sulcus, and the smooth areas of the fold are called the gyruses. This diagram of the brain structures labels the parietal, occipital, frontal, and temporal lobe, also the cranium and the cortex, along with the cerebellum, basal ganglia, brainstem, dura, and spinal cord. We will go over them shortly. It's important to note that the left and right hemispheres of the cerebral cortex are nearly symmetrical. The hemispheres are connected by the corpus callosum. The corpus callosum is the largest white matter structure in the brain. The brain is typically divided into hemispheres, the right and the left, into 4 lobes, frontal, occipital, parietal, and temporal. Each lobe is named after the skull bone that covers it. This is a term that I didn't quite understand when I was a nurse, and it took me getting into the neurology world about dominant hemispheres. So I just want to touch base on that. Throughout the lecture, I'll give you my teaching points that no one really explained, and it took me a long time to understand. So dominant hemisphere is the term that's used to describe where someone's language center is going to be. So if you're right-handed, your language center is on the left hemisphere. Hence, this is why our notes always tell you what handed a patient is. For example, this is a 56-year-old right-handed man with past medical history, high blood pressure, hyperlipidemia, diabetes. I've told you a significant amount of information by telling you that he's right-handed. So you know his dominant hemisphere of his brain is the left side. The functionality of the cortex is commonly described as the 3 parts, sensory motor, and the associated areas. Here's your frontal lobe. It's for high-level cognitive function. It initiates swallowing, inhibition, insight, judgment, language, long-term memory, motor planning, personality, problem-solving, reasoning, socialization, sexual behavior. The frontal lobe is located at the front of the brain over the eyes. It contains the olfactory bulb. The frontal lobe also contains the motor cortex, which is very, very important for motor planning and implementing movement. It also contains dopamine-sensitive neurons. The dopamine system is associated with the reward, attention, short-term memory, task planning, and motivation. Dopamine tends to limit select sensory information that the thalamus sends to the forebrain. The frontal lobe is also considered to contribute to our most human qualities. Damage to the frontal lobe can result in changes in personality and difficulty planning. Frontal lobes are the most uniquely human of all of the brain structures. Here's a picture of your homunculus. The frontal lobe contains the motor strip. It lies in the back of the frontal lobe. The motor strip controls voluntary motor function. The dominant frontal lobe houses the Broca's area, so language processing and speech production. If you had an injury here from a stroke, it would cause a non-fluent aphasia. We're moving on to the parietal lobe. The main function of your parietal lobe is to process somatosensation like touch, sensations such as pressure, pain, heat, and proprioception, the sense of how the body is oriented into space. Also, the parietal lobe integrates information from various senses and assists in the manipulation of objects. Portions of the parietal lobe are involved with visual spatial processing. I think it's interesting that if you have injury here, you can have agraphia, which is unable to identify letters written on your skin. So that would be like if I had you hold out your hand and wrote the letter A, you might not be able to recognize it. Moving on to the temporal lobe, it's located at the base of the brain by the ears. It is primarily involved in processing and interpreting sounds. It also contains the hippocampus, which helps with memory formation. Primary auditory cortex is here, so the distinction of sound quality, short-term memory. This is also where Wernicke's area is, which is language processing and speech interpretation. This area can have a fluent aphasia, which means you would be able to talk to me, but it wouldn't make sense. The temporal lobe is also noted to be an area of the brain which has frequent seizures, and I bring that up because a lot of my patients who have strokes in the temporal region do have a high propensity for post-stroke seizures. The occipital lobe is located at the back of the brain. It is primarily involved in the vision, seeing, recognizing, identifying the visual world. Any injury here can cause severe visual impairment. The cerebellum. The cerebellum looks like it's a separate structure attached to the bottom of the brain. It plays an important role in motor control. The cerebellum is essentially, it is essential for making fine adjustments to motor actions. Like the cerebral cortex, the cerebellum is divided into two hemispheres. It contains a narrow midline zone that's called the vermis. The surface of the cerebellum is covered with finely spaced parallel grooves in striking contrast to the broad, irregular areas of the cerebral cortex. These parallel grooves conceal the fact that the cerebellum is actually a continuous thin layer of tissue, tightly folded into like an accordion. The thin layers contain several types of neurons with highly regular arrangement. Most importantly, the Purkinje fibers are here in the granular cells. This complex neural network gives rise to a massive signal processing capability. Almost all of its output is directed into a small, deep cerebellar nuclei laying into the interior of the cerebellum. So this is really coordination, balance, equilibrium, muscle tone. Injury to the cerebellum can lead to ataxia or lack of coordination, inability to gauge distances, speed, or power of movement associated with muscle function, inability to perform rapid alternating movements, gait problems, problems with equilibrium, blurred speech, nystagmus. I think of cerebellar infarcts to look like a drunk person, truthfully. They're staggering, they're dysarthric, lack of coordination. You then have your brain stem, which is comprised of 3 structures: your midbrain, pons, and medulla. The brainstem gives a rise to cranial nerves 3 through 12 and provides the main motor and sensory innervation to the face and neck via the cranial nerves. Through this, though it's small, it's extremely important part of our brain, as the nerve connections of the motor and sensory systems from the main part of the brain. It communicates with the peripheral nervous system through the brainstem. This includes the cortical spinal tract, the posterior column medial lemniscus, which does the fine touch, vibration, sensation, and proprioception. It also contains the spinothalamic tract, which is pain, temperature, itch, and crude touch. The brainstem also plays an important role in the regulation of cardiac and respiratory functions. It regulates the CNS, or the central nervous system. It is pivotal in maintaining our consciousness and regulating our sleep-wake cycles. The midbrain is associated with vision, hearing, motor control, sleep and wake cycles, alertness, and temperature regulation. The pons lies between the medulla oblongata and the midbrain. It contains the tracts that carry signals from the cerebrum to the medulla and the cerebellum. It also has tracts that carry sensory signals to the thalamus. Cranial nerves 5, 6, 7, and 8 originate here. The medulla oblongata controls autonomic functions and connects higher levels of the brain to the spinal cord. It's responsible for regulating several basic functions of the autonomic nervous system, like respiration. It's your cardiac center, so your sympathetic and your parasympathetic system are here. Vasomotor center for your baroreceptors. It also has reflexes for cough, vomiting, sneezing, and swallowing. And then cranial nerves here are 9, 10, 11, and 12. The medulla is the reason why our brain controls the contralateral side. The corpus callosum, it's Latin for tough body, which is, so the corpus callosum is a thick fibrous bundle. It connects the 2 hemispheres. It allows information to be passed from one side to the other. The right hemisphere controls process signals for the left side of the body, while the left hemisphere controls the process signals for the right side of the body. The corpus callosum forms the roof of the lateral and third ventricles. Just want to point out here, sometimes a stroke mimic is multiple sclerosis. Whenever you're looking at the MRIs of patients with MS, you might see comments about Dawson's fingers, which is the demyelinating plaques associated around the corpus callosum. The basal ganglia. Basal ganglia are a group of nuclei of varied origin in the brain. It acts as a cohesive functional unit. The functions, including voluntary motor control, procedural learning relating to routine behaviors or habits, such as bruxism, eye movements, cognitive and emotional functions. The basal ganglia the basal ganglia plays a central role in a number of neurological conditions, including Parkinson's and Huntington's disease. I do want to point out here a tidbit or a teaching point. I can count at least 3 to 4 patients who've presented with a hemoglobin A1C of greater than 16 who come in with hemibolismus or dance-like movements, and they're found to have basal ganglia strokes. So when putting together this presentation, it really hit home about the basal ganglia controlling voluntary movement, because these patients, and it controls some involuntary movements, because these patients couldn't stop the hemiballismus, but that's just a little bit of teaching from that experience. The limbic system is a set of structures that does a variety of functions, including emotion, behavior, motivation, long-term memory, and smell. It operates by influencing the endocrine system and the autonomic nervous system. It is highly interconnected with the brain's pleasure center, which plays a role in sexual arousal, and it's the high you feel from recreational drugs. The hypothalamus is found deep in the temporal lobe. It's this seahorse-shaped structure. It's responsible for memory. The amygdala is a small almond-shaped structure deep inside the limbic system. In the inferior region of the temporal lobe, it plays an important role in the mediation and the control of activities and feelings such as love, friendship, affection. The amygdala is the center for danger identification and a fundamental part of self-preservation. The thalamus is perched on the top of the brainstem near the center of the brain, with nerve fibers projecting out to the cerebral cortex. It helps relaying sensory and motor signals to the cerebral cortex, regulating consciousness, sleep, and alertness. It likely acts as a relay between a variety of subcortical areas and the cerebral cortex. Of note, patients that come in with complaints of one-sided sensory loss usually have the contralateral thalamic infarct. The hypothalamus is a small part of the brain located just below the thalamus on both sides of the third ventricle. It plays a role in emotion. Specifically, the lateral part seemed to be involved with pleasure and rage, which the medial part is linked to things like aversion and displeasure. When physical symptoms of emotion appear, the threat they pose returns to the limbic centers via the hypothalamus, then to the prefrontal nuclei, increasing anxiety. A patient presents to the ED for a fall. Patient reports dizziness, nausea, and incoordination of the right leg. On exam, you note heel to shin is incoordinated with the right leg. The patient's also unable to ambulate with a steady gait. If the MRI is positive, where would you suspect there be a stroke? So we went over some of these, we went over all of these lobes of the brain. We said that the occipital lobe has a lot to do with our vision. The temporal lobe has a lot to do with speech and our auditory cortex. The cerebellum has to do with incoordination, fine muscle movements, gait, and it also houses the fourth ventricle, which is the nausea, which can, if injured, can cause nausea and vomiting. Or we have the parietal lobe, which does a lot of sensory somatization. So the correct answer here would be the left cerebellum. I don't see what y'all had chosen. I apologize.
Hi, Stacy, it's Deanna. It's processing.
Oh, it's okay. Perfect. Looks like roughly half answered, and everybody got the left cerebellum. We'll move on to the cerebral spinal fluid. This is a clear, colorless body of fluid. It's found in the brain and the spinal cord. It's produced by the epididymal cells in the chordae plexus, which the chordae plexus are a part of your ventricles. There's about 125 milliliters of cerebral spinal fluid at one time, and you generate approximately 500 milliliters a day. CSF, or cerebral spinal fluid, acts as a cushion or a buffer for the brain. It provides basic mechanical and immunological protection to the brain inside the skull. CSF also serves as a vital function in cerebral auto regulation of the cerebral blood flow. It occupies the subarachnoid space, which is between the arachnoid matter and the pia matter, as discussed earlier. The ventricle system around the inside of the brain and spinal cord. It fills the ventricles of the brain, cisterns and sulci, as well as the central canal of the spinal cord. The ventricles are the drainage system of the cerebral spinal fluid. As outlined by the picture, you'll see the lateral ventricles, which are yellow and purple. They're connected by the foramen of Monroe, which is the dark purple, which connects to the third ventricle, which is that fuchsia color right in the middle. The aqueductus sylvius is presented as green in the picture in the midline. The fourth ventricle is this light blue. You have the foramen of Luschka, which are basically appendages that come off of the fourth ventricle, and that is how the cerebral spinal fluid goes to the subarachnoid space. Right under the light blue structure, which is the fourth ventricle, you have the foramen Meninges, which connects to the central canal of the spinal cord. We're moving on to cranial nerves. Cranial nerves are nerves that emerge directly from the brain, in contrast to spinal nerves, which come from the spinal cord. We have 12 pairs of cranial nerves. The first and the second pair emerge from the cerebrum, and the remaining cranial nerves 3 through 12 emerge from the brain stem. I think that this is interesting. Each pair of cranial nerves affects the same side of the brain or face, except for cranial nerve 4, which is the trochlear nerve. And here you see the reason that the cranial nerve 4 does not do its lateral side is because it makes a loop around the periaqueduct. On this slide, on the left of the table, I've given you the cranial nerve numbers, which is always written in a Roman numeral, and the cranial nerve name. You'll then see the mnemonic to help you remember the names. On old Olympus towering tops, a Finn and German viewed some hops. So I think that probably rings a bell back from nursing school, followed by the mnemonic to help you remember if the nerve has sensory, motor, or both in its functionality. Some say marry money, but my brother says big brains matter more. Cranial nerves 1 through 6 are depicted in this table. Cranial nerve number 1 is olfactory. It transmits smell. Cranial nerve number 2 is the optic nerve, transmit information from the retina to the brain. Cranial nerve 3 is your ocular motor. It's big in eye movements. It does pupillary constriction and lens accommodation, and that's where you're testing your cranial nerves and then you bring your finger into the nose. You'll see the eyes move down and inwards. And then it also controls upper eyelid movement. Cranial nerve 4 is the trochlear nerve. It allows your eyes to look down and inward. Trigeminal, it has 3 branches. That's why whenever we're testing sensation on the face, we need to make sure we're doing it on the forehead, in the maxilla region, and the mandible region. And it also helps control motor function for chewing. Cranial nerve number 6 is the abducens, and it allows the eye to move outward. You have your cranial nerve 7 is your facial nerve. It transmits sensory and motor function from the ear, controls the facial movements and sensation to the taste of the tongue. Cranial nerve 8 is your acoustic nerve, which transmits sound. Cranial nerve 9 is your glossopharyngeal. It has sensation and taste to the back of the tongue. It controls the pharynx during swallowing and talking. Your vagus nerve is cranial nerve 10. Sensory innervation to the pharynx, larynx, and thoracic and abdominal viscera, your heart, your GI tract, your taste receptors. So this one does a lot, your vagus nerve. Your cranial nerve 11, your spinal accessory. It controls the muscles of the soft palate and the pharynx. Your spinal branches control your trapezius and your sternocleidomastoids. Your hypoglossal nerve innervates the muscles of the tongue. There is question number 3. A patient comes into the ED and complains of right facial droop worsening over 3 days. On exam, you note he's unable to completely close the right eye, elevate the forehead, and has a right facial droop. You anticipate the diagnosis to be, so we talked about the cranial nerves innervate the same side, so we know that this has to do with the right side. All of the symptoms were right-sided. So cranial nerve 7, which controls the facial movements, on the right side. So we think that this is going to be a Bell's palsy, the way we would, some institutions diagnose it by an MRI brain with and without contrast and looking for enhancement of that cranial nerve 7, but that's what we would think. We'll move on to cerebral blood flow. As we've stated, the cerebral blood flow to the brain is at a rate of 750 cc's a minute. The brain receives about 15% of your cardiac output at any given time. It consumes 20% of the body's resting oxygen supply, and there is no storage of oxygen in the brain, so that's why adequate blood supply is necessary to maintain your cerebral metabolism. And if it's not maintained, then you'll have cerebral ischemia. Let's move on to the vasculature. Here's a picture of your aortic arch and the 3 vessels off of it. You have your brachiocephalic or your innominate artery. On the right side, it's going to come off of the aortic arch. It branches off into the right common carotid artery to the right subclavian artery. On the left side of the arch, you have your common carotid and your subclavian. Of note, both common carotid arteries will have a bifurcation into the internal carotid artery and the external carotid artery, and our vertebral arteries come off of the subclavian artery. I don't know if y'all heard of the diagnosis subclavian steal syndrome, but this would be the picture I would look at whenever you're discussing those patients to really understand direction of flow. This picture on the left is a good picture of the view of the posterior circulation. It demonstrates your bilateral vertebral arteries and then they're going to form the basilar artery. At the very top of your basilar artery, you have your posterior cerebral arteries. And then you have your posterior communicating arteries that meet with your middle cerebral arteries, then to your anterior cerebral arteries, which are then connected by the anterior ACOM. Your internal carotid arteries, these supply blood to the anterior portion of the brain. They divide into the middle and anterior cerebral arteries, and then they're connected to the posterior circulation via the PCOM. The anterior circulation in your ACAs, they originate from the internal carotid artery, the anterior portion of the circle of Willis. They supply the most medial part of your frontal lobes, If you have an LVO or large vessel occlusion of the anterior circulation, you should be concerned about leg weakness and the ability to walk. Here is a picture of your ACOM. It connects the left and the right ACA arteries. Your middle cerebral arteries branch from the internal carotid. They supply blood to the frontal, parietal, and temporal lobes. Your vertebral arteries, which are depicted here, as I stated, join together to form your basilar artery. So this supplies blood to the brainstem, cerebellum, occipital lobes, and the posterior temporal lobes and thalamus. Your basilar artery is formed by the vertebral arteries. The arteries supply the blood to the brainstem, cerebellum, occipital lobes, and posterior temporal lobes and thalamus. The PCAs branch from the tip of the basilar. They supply blood to the midbrain, occipital lobe, and thalamus. Here's a good picture of a PCOM, or a posterior communicating artery. It's the connection between the posterior and the anterior circulation. It supplies blood to the optic chiasm and optic tract in the posterior hypothalamus and part of the thalamus. If you're looking at the picture, you are right. The patient does not have a left PCOM. He only has a right one, but it was a good visualization. I added this on. I wasn't necessarily tasked to talk about it, but I really think that this is the most important part of this lecture, understanding and applying the knowledge of neuroanatomy to what we do every single day. So this is a CAT scan of the brain. A CAT scan is a non-invasive diagnostic test. It uses X-rays and computer technology. The X-ray beam moves in a circle around the body and then allows us to make 2D pictures. As part of the stroke team, my job is to evaluate every CAT scan, or every patient's CAT scan to see if there's an identifiable neurological condition such as hemorrhage, which shows up as bright white, ischemic stroke, mass, or thrombus in the vessel. I do want to point out that CAT scans are as if a patient is laying on the CAT scan table, you're at the end of the bed at the feet, and the pictures are going to start at the brain stem. You'll see the cerebellum, moving your way up to the very top of the head. So I think orientation is super important to know. When you're looking at the CAT scan screens, you'll see sequences and images on the upper left. You always know the right side and the left side of what you're looking at because the screen tells you there's a R for patient's right side and a left for patient's left side. Some people say that the contrast to whiteness should be 30-30 when viewing images for stroke. You can always remember when evaluating a CT of the brain that blood can be very bad. This mnemonic helps remind us what we should look at. So here you'll see the different types of hemorrhagic strokes. Blood appears bright white. It's typically in the range of 50 to 100 Hounsfield units. You'll see epidural, subdural, intraparenchymal, intraventricular, and subarachnoid bleeding here. The epidural is the very first picture. It's the lens shape. It does not cross the suture line. And then you see on the second picture, you'll see a subdural hematoma, which is the crescent on the right side with pushing the right over to the left. So you do see some midline shift, but the right subdural. The next picture is an intraparenchymal hemorrhage, meaning it's in the tissue of the blood. The top picture to the right side of the screen is an intraventricular, bleed, and then that's a pretty classic, very bad subarachnoid underneath it. The cisterns are any openings in the subarachnoid space of the brain, and it's created by a separation of the arachnoid and pia mater. These spaces are usually filled with cerebral spinal fluid, so you're just making sure there's no blood here whenever you're looking at a CAT scan. Things I look at are symmetry. You want to make sure that the sulci and gyri appear the same on both sides. It's easiest when the patient is not rotated in the scanner, so they need to be laying straight with their head still. We're looking at that gray-white differentiation. It's the earliest sign of a stroke on CAT scan is the loss of gray-white interface. You compare side to side. You want to look for any shift of the midline. Look at the ventricles. Do they look the same? And you're going to check for any effacement of the sulci. Hyperdensity and hypodensity, blood is bright white, so it's hyperdense. And then air and fat and tumor can be hypodense, and that's the same as with a stroke. I just want to point out your ventricles on CAT scan. We talked about them earlier. You have a third, fourth, and your lateral ventricles. You're looking for dilation, compression, or shift. And then, of course, we need to look at the bones. The bone has the highest density on CAT scan. It's the widest in appearance. You're looking at it for fracture. And then here's a CAT scan of the brain. I just to close all of this neuroanatomy. This was actual patient on service, or recently was on service. This was a 56-year-old gentleman. He came in with hypertension, hyperlipidemia, and diabetes. He had dizziness, nausea, and difficulty walking. You can see here that the red arrow is pointing to the left vertebral artery, and it looks hyperdense. And then I showed you what the couple sequences later of the CAT scan, it does demonstrate hypodensity in the left cerebellum, which we know that the left vertebral artery does supply that area of the brain, and you see early signs of stroke. Thank you for listening to this lecture. I know neuroanatomy is a bit heavy. I hope that you've also enjoyed some lunch at this time. If you have any comments or questions, I'm available. Here's my contact information, and I'm very happy to answer anything offline as well. I do realize that my email address is wrong. It is srmoye, so S is in Stacy, R is in Renee, MOYE at houstonmethodist.org. Thank you very much.
If anyone has any questions they would like to ask, you can star 1 your line to unmute yourself.
Thank you very much, speakers. Again, participants, if you would like to ask a question, you may please press star followed by the number 1. Please unmute your phone and record your name clearly when prompted. And speakers, you do have one on queue. Please stand by as I obtain the name. One moment. Thank you for patiently waiting, speakers. Our first question comes from the line of Allison. Your line is now open.
Hi, Stacy.
Hey.
Thank you so much for your lecture today. I didn't necessarily have a question, but I just wanted to say it was full of valuable information, and I just thought it was really great. It was robust, and it went through all of the kind of high points that you need to know as a stroke coordinator. So if there's any other coordinators out there that have questions, I would encourage them. Stacy is a wealth of information.
Thank you.
Thank you. Speakers, at this time, there are no further questions. So once again, participants, if you would like to ask a question, please press star followed by the number 1 and record your name clearly when prompted. You may also press star 2 to cancel. At this time, speakers, there are no further questions. You may proceed.
Thank y'all.
Thank you, everyone, for attending. Just a reminder, we'll be sending out a link with the presentation and a recording in about a week from today's webinar. Thank you so much.
Thank you, everyone. That concludes today's conference. Thank you all for participating. You may now disconnect.